Good afternoon, everyone. Well, let's go ahead and begin the webinar. I know people are still logging on. I want to welcome everyone to EHI webinar, A Patient, Provider, and Technologist Walk into a Hospital. Perspectives on the impact of data-driven remote care programs. This is such an interesting topic, and we're going to have a panel that is going to go through the details of data-driven remote care and how it works and the value. It's such an important topic today as there's such an increased use of wearables, wireless devices, and consumer apps. So we're really looking forward to this discussion. The agenda includes Ashley Needham, who's the Director of Corporate Initiatives at Validic, Martin Entwistle, President of Aries Health System, Steve Van, who's a patient champion, and Drew Schiller, who's the CEO of Validic. And just to give you a little bit of information about our panelists, Martin is the President of Aries Health, and this is a company providing solutions to increase patient engagement and population health systems. Martin has a really impressive background, previously at Sutter Health, also at Palo Alto Medical Foundation, as well as other organizations. And for further information about the presenters, it is on the EHI website. Steve Van, who is the patient champion, was diagnosed with type 2 diabetes at the age of 40. And after struggling to manage his condition, he joined a pilot program which used home health devices and wearables. Steve will talk more about this in today's webinar. And Drew Schiller is the CEO and co-founder of Validic. He also serves as a leader on many boards, including eHealth Initiative, as well as the Consumer Technology Association of Health and Fitness. So we have a really fabulous panel. It'll be a little different today as it will be a panel discussion. So less slides and more opportunity to hear from people and their experiences. But before we get started, just a few housekeeping topics. All of the participants are muted. At the end, there'll be an opportunity for Q&A, and as you can see on your screen, there is a chat line as well as a Q&A line. The chat is really used if you have any technical difficulties, and the Q&A is obviously for questions, and it really helps us if you use the Q&A, because if we don't get a chance to respond to your questions, this is saved and we can respond at a later time. And then we don't have that many slides, but we will have the whatever slides we do have, as well as the sound, available on our website. Just a few background information on eHealth Initiative. Our mission is to serve as the industry leader, convening executives from multi-stakeholder groups to identify best practices to transform healthcare through use of technology and innovation. We conduct research, education, and advocacy activities to support the transformation of healthcare. You can see from this slide, we have such a wide array of different members, from payers, providers, pharma, vendors, state government, federal government participation. So it's wonderful to have this wide variety of people contributing to the information that we provide on these webinars, as well as we have different roundtables and EHI work groups. The work groups that we currently conduct right now are value and reimbursement, technology and analytics, and workflow for providers and patients. After each of the work groups, we provide a best practice, and we actually are using these best practices to send out to both members and non-members. So keep a lookout for these best practices. We've had some fascinating discussions on these work group calls, and we're willing to share with the greater stakeholder community. So on our website, we have a resource center where we add these best practices, as well as other research with white papers and other reports and presentations. So if there's information that you'd like to send to us and that we can add to the resource page, please don't hesitate to let us know. Also, we have a report on patient-generated health data, and this is also on our website, so please take a look at this interesting report. Again, I want to thank Validic for their generosity in supporting this webinar. We could not do this without the support of organizations and companies such as Validic. So I want to thank Validic and the people that are participating today. And on that note, I'm going to pass this on to Ashley. Ashley Needham, who's the Director of Corporate Initiatives at Validic. Ashley?
Thank you, Claudia, for the introduction. Hello, everyone, and welcome again to today's webinar, A Patient, Provider, and Technologist Walk into a Hospital, Perspectives on the Impact of Data-Driven Remote Care Programs. I'm Ashley Needham, and I am thrilled to be your moderator for today's discussion. We're joined by three incredible voices and perspectives in healthcare to talk about their experience with both remote care programs and the utilization of patient-generated health data. One item to cover off before I formally introduce the speakers. Feel free to join the conversation on Twitter following the hashtag 3voicesonPGHD or on the Twitter account @Validic. We'll be sharing insights from today's speakers as we go along and encourage you to share your thoughts as well. On today's webinar, we're going to hear from three distinctly different and insightful stakeholders. First, a patient with type 2 diabetes who has nearly 2 decades of experience with traditional and remote care programs to manage his conditions. Please welcome Steve Van. Second, we're joined by a provider with decades of experience developing, deploying, and managing data-driven care programs aimed at disease prevention and management. Please also join me in welcoming the President of Aris Health Systems, Dr. Martin Entwistle. And finally, a career technologist who has spent nearly a decade trying to improve the utilization of patient-generated health data and home health devices throughout healthcare and wellness. Please welcome CEO and co-founder of Validic, Drew Schiller. These three individuals are going to share their perspectives and experiences as to the value that PGHD and digital health devices offer remote care programs, and by extension, what these tools offer patients and providers alike. So with that, let's begin. Martin, Steve, and Drew, thank you all for joining us today. For all three panelists, it would be great to start with each of you detailing your experiences with PGHD as part of care delivery. So Martin, why don't we start with you? Can you talk a little bit about your experiences with the use of PGHD for patient care and where and how this has impacted the care delivery process?
Well, thanks, Ashley, and welcome, everyone. Thanks for joining in. So, obviously, there is a story and a journey here to be talked about. My involvement in this goes back quite a number of years, and you've heard that I was working previously at Sutter Health. And within our innovation program, about 10 years ago, we had in mind that we needed to develop a different approach to the management of patients, particularly with chronic disease, with a view to also extending that into prevention. We recognized that important in that would be engaging the patient, making this patient-centric, reflecting the clinical goals that have already been determined as part of their care plan. Help a patient understand where they're at in terms of progressing against those goals, and support them to make positive changes in behavior. At the same time, provide information to care teams and physicians so they get better insight into the progress or otherwise that their patients are making day to day when they're not in front of them in the office or in the hospital. We recognized to do that job, we needed to have information about how an individual was doing in their day-to-day lives. And that got us into the realm of patient-generated health data. We started initially with collecting information for patients with diabetes off their glucometers. And you can imagine 8-10 years ago, that was quite a technical challenge. So whilst we were focused on the clinical care delivery process, we were also focused on how you would collect and use for improvements in care the patient-generated health data then available. We evolved the approach, the platform, if you will, that we used to do that. And that took us in a number of areas of trying to improve the quality of the data, the scope of the data, so we could cover more conditions and more dimensions of behavior. And behind that, of course, we were then deploying this into programs of care. So it's an interesting exercise to collect patient-generated health data, but at the end of the day, if we don't deliver that into clinical practice, we are not going to achieve improved outcomes. And so quite a lot of our work was working on the challenges of deployment. How do we make that information available appropriately, both to patients at the right time, real-time feedback being a key dimension of that. How do we feed it back to providers in their workflow? Sutter Health, as people are possibly aware, uses Epic, so that required us to do integration to electronic health records. And we were reasonably successful iterating over time at developing and deploying those programs into usual care, supported by practitioners, physicians, care teams, nurse educators, supporting their patients as part of day-to-day workflow. We've published a number of papers with results, and some of our results were very encouraging as to the ability to improve outcomes, ability to maintain sustained engagement in those programs. But we also learnt a lot in terms of ways to improve and opportunities for further advancement. Since I left Sutter Health a year ago, we've also been working on other challenging areas. So Sutter Health is representative of a larger integrated delivery system, but of course there are many other settings for delivery of care. Recently I've been working with the other end of the spectrum, smaller individual practices. How can we deliver these kind of solutions into that environment? Also some interesting work too with delivery into networks, such as making these kind of programs available within health information exchanges, because there are very good and rich sources of data available there. So I guess actually bottom line summary is that we have adopted and used patient-generated health data because it helps us understand how a patient is doing, progressing against the clinical goals day to day, helping the patient engage, helping them make positive behavior changes, and helping the care teams know which patients need attention, and working that back into usual care. The results, are positive and encouraging, but there's definitely more work to be done and more to be learned in this space.
Thank you, Martin. And Steve, can you talk a little bit about your experience having been part of a remote monitoring program that incorporated your data and why you sought this kind of program out?
Well, yes, I can. Thank you for having me on this panel. And as the voice of the patient, which I really appreciate, let me start with the second part of that question first. Why did I seek other treatment? And the bottom line for me is that the treatment that I was receiving, the care that I was receiving under my past provider just wasn't working. I would go in and get my normal quarterly A1C test with a follow-up doctor's visit, and my numbers wouldn't change. My blood sugar values were just consistently out of range. I tried to change some of the behavior I had in that program, but there was no result that was positive for me. So I looked around and I found another program. And it took the leap of faith, because leaving your doctor's kind of risky, going someplace that you don't know of. And I moved over to this new health system. And what they did for me is they looked at my care. I look at, as a patient, I look at healthcare in general. As I go in there and I get diagnosed, and I have a follow-up treatment plan. So I was diagnosed with diabetes, treatment plan is insulin. And then the care part was much different here. What they were doing in this case is they were looking at my activities on a more detailed basis. They were looking at my blood sugar values on a daily basis instead of a quarterly basis, so that they could take a look at my daily behavior and give me feedback. I thought this was such a great and positive arena to be part of. It was very easy. I take my blood sugar anyway. All I had to do is take the iPhone that I carry with me every day and take a picture of it. and send it up to this magical cloud, and my providers got it. And what I didn't know while I was doing this is that they were behind the scenes looking at all this data. And they were looking at my behavior on a daily basis. And I would go in and see my nutritionist, care provider, and endocrinologist, and they would give me feedback. And, first it was a little feedback, but then they got a really good profile. When they got a profile of me, they started talking in more detail about my behavior on a throughout-the-day basis. This reminds me of one little scene, an experience I had with my diabetic educator. She was looking at the numbers and she said, "Steve, what's going on in the evening with you?" I said, "Look, I have dinner. My dinner's really good. My wife and I sit down and we watch Netflix. My kids are in college, so we have, our own time. We can watch whatever movies we want. And I have some snacks and stuff." She says, what are you eating?" I said, "I'm eating healthy." She says, "Well, what is it?" I said, "It's popcorn." She says, "Steve, popcorn will raise your blood sugar." This was an incredibly powerful moment for me. It was a one-to-one relationship. What I thought was healthy wasn't healthy. And as a result, I took that out and my eating numbers changed. It was a one-to-one relationship. And it caused me to begin to have a dialogue with my providers in a much different way. I wasn't just told what to do. We could have a back and forth with this. And I could begin to see and look at my behavior, which I thought was good. But when I look at the details and the information that I share with them on a daily basis, which was not hard, I could see a change. And there was a big change for me. For me, it changed my whole way of managing my health. I looked more into details. It also made a better pathway of communication between my provider and I. And it's the experience that I thought was positive and results I use every day.
Steve, thank you so much for sharing that experience. And Drew, as a technologist, you have a very different perspective on how data can influence and impact care. Can you share your experience with PG and how some of your clients and partners are implementing these data into care programs?
Yeah, absolutely. Yeah, thanks. And again, happy to be here just as everyone else. I think it's really important to share a little bit of background for those in the audience as well around how Martin and Steve and I actually originally got connected, which is that Martin and I had been working together on a remote monitoring program that Steve actually described. And as part of a pilot demonstration to demonstrate how patient-generated health data can impact patient care that was sponsored in part through the ONC, we created this program and Steve was able to participate. And what we did was we connected the data from patients, so blood glucose monitoring, as well as blood pressure, weight, nutrition app, which is how they were able to understand what Steve was eating, et cetera, into the clinical workflow of the EHR for the care team to understand what was happening in the environment. And what was really important about this program is that, as Steve mentioned, it allowed for the data to actually change the conversation between Steve and his care team, so that they could focus not on, well, you should be doing this, but hey, what's actually happening here? And we're actually seeing this start to take off in a number of other places inside of healthcare. So for Validic, we connect patient-generated health data from hundreds of disparate sources, which includes wearables, in-home medical devices, like blood pressure monitors, glucose meters, pulse oximeters, weight scales, et cetera, as well as health apps on the phone. And we standardize and normalize the data into a common ontology, provide one simple connection for delivery and display into the clinical workflow to enable these kind of programs. And so as a part of this, what we're seeing is that our clients are starting to really take hold. In fact, we're working with a large IDN based on the West Coast. It's a top 3 IDN, and they've deployed this program to close to 10,000 patients that have either diabetes and hypertension, and they're really starting to scale this program out, and they're looking at also rolling this out not just in those common disease states, but across 15 to 20 disease states over the next 5 years. And what we're seeing is that the power that the data provides for the providers to actually interface with their patients in new ways is tremendous. One of the things that we learned while we were doing this pilot demonstration was that one of the physicians who was interfacing with Steve, he also manages type 1 diabetic patients. And the way that he described how he managed type 1 diabetes was shocking, because he said that what he would do is he would prescribe his type 1 patients a continuous glucose monitor, but there was no way for that data to actually get into the clinical workflow with any sort of data way, right? There was a PDF static display that he could get, but he couldn't actually get the data. And so as a result, what he would do is he would have the patients log into their CGM portal and share their data with him via email, like as if he were a family member or friend. And then this physician would actually go home in the evenings and pull up his personal laptop and log into the CGM website, look at the data from the patients we're collecting, and then open up his work laptop that had Epic and type in patient notes. And that was the most effective and efficient way for him to actually care for his patient population. He understood the value of the data. The challenge is he couldn't actually access the data in a meaningful way. So we're starting to now see, this was a couple of years ago, we're starting to now see movement in the space where the patient-generated health data is being brought to the clinical team in a way that's integrated into their solution so that they can provide proactive care.
Thank you, Drew, for providing that insight and background. So now let's talk about some of the barriers we hear to accessing and adopting PGHD and remote care programs. There have been numerous studies proving the ROI or efficacy of these programs, yet challenges remain. So Martin, can you talk about what challenges to integration or adoption you face, and what approaches you've taken to address these that others on the call could learn from?
Yes, thanks, Ashley. Well, building on what we just heard from both Steve and Drew, there are certainly still issues with the data and the devices, and those are the areas that people tend to jump to. Reliability of data, accessibility of data. I'm going to go beyond that, because I think that those issues, while they do exist, are not necessarily the biggest ones that we face today. But just sticking with the data concept, in reality, most clinical teams don't really want the data. They want the interpretation of the data. Help me understand what this means in the context of the patient or population I'm managing. So I think the way we use the data represents challenges, which is that some level of interpretation is required in order to feed back meaning, whether it's to the patient or the care team. So there are some challenges there, and to some extent that depends on the technology, the system, the model you're going to use to do that job. So some of the bigger challenges you've heard both Steve and Drew allude to, I think relate to workflows. It's how do we get this information, the intelligence, appropriately linked into both the patient, the individual's workflow, when's the right time to be collecting data, the right time to be feeding it back, that teachable moment, if you will, and similarly for care teams. And that involves a level of integration into the existing systems that people are using, whether that's a portal, it's an app, whether it's the clinical information systems, EHR, population health, because it's still not as easy as we hope it could be to do those integrations. So that's another challenge that is a fairly significant barrier, because if we're expecting people to hop around in the way Drew just described, go to a different app to find the information, most people don't have the time or the tolerance to do that. So we're missing opportunities to use rich information for patient care. Another one, to be honest, is that if we think about the process that we're talking about, it really is driving change in practice approaches. We're redesigning the way we care for and treat patients. Many people still have been trained to interact with patients face-to-face, and patients similarly used to coming to see the physician care team in bricks and mortar. And now all of this is about driving really remote patient care. And so understanding in some detail the workflows that enable that process, skills, training, roles, responsibilities that enable people to follow those processes for remote patient management are also important. And that leads us down the path of re-engineering practice design, workforce education, feedback loops, etc., to look for opportunities for ongoing and rapid agile improvement, if you will. So those are a number of areas that I see, Ashley, that I think some of the biggest barriers today are not so much around the technology. That's not to say they don't exist, but it's more about how we interpret data into meaning, and then how we deliver that into workflows that themselves are where we will get impact in patient care and outcomes.
Could not agree. Thank you, Martin. Great points made. Steve, one barrier that we hear from providers is that patients don't want these kind of programs, or they won't engage with these programs. They're too onerous or involved. What are your thoughts on this sentiment?
Every time I hear this, it really upsets me. What you're telling me is that you've got an answer or a solution for me, but I won't execute. I won't use it. And to me, that's just an arrogant statement. We are people, that come from all walks of life and have all abilities. So if you have a solution for me, give it to me. Don't diminish my skill level or my interest. When you have diabetes or a chronic condition, it's an onerous part of life. It's with you at all times, every second of every minute of every hour of every day. You don't get rid of it, and you tell me that I wouldn't sign up for a solution, breaks that relationship up. So I say, ask the patients, we will. I know that the program that I was in was painless, and they incorporated it into my lifestyle, into, I would say, most of our lifestyles. And I would say that we, moving forward, need to create a partnership where you bring us into it, bring us into the design, instead of saying that we won't get involved, it's too onerous. Help us with that. Right now, we as patients also need to embrace this, and that will happen when trust builds. I think that, when the doctor tells me or gives me an order to go out there and be healthy, eat well, exercise, those are really big boulders that I have to move around. And I'm trying to figure out, as a person with this disease, how do I do this in my everyday life? It all sounds good in the doctor's office, but when I leave that office, I'm in the care mode. And how do I make this thing work? What tools do I have to be able to successfully keep my blood sugar at a very consistent low level? And right now, diabetics have very few tools. It's like asking a person to drive from San Francisco to New York in a car without a map. The best thing they can do is follow the morning sun. If you give me a GPS, I can get there, and I know I can get there. Give me the tools. Create that partnership. Let's begin to have a dialogue. Not a monologue. Instead of giving me an order, let's talk about how we can do this. Bring some technology into this in our everyday life that we already use that'll guide us along the way. And I think, that partnership will bond much better. In my experience with the last program, my doctor was talking doctor. and I was talking patient. And, we just couldn't connect, What I learned through the program is that we started to have a common language with the numbers and everyday information that I was providing. And that common language became entered into our language so that we could have a dialogue. And we weren't talking from two different sides, that we had a common understanding of how to get there and track ourselves along the way. Give us the tools. We can do it.
I love the parallels you pulled in to help us feel your experience. Thank you, Steve. Drew, what do you think is going to catalyze PGHD into this next phase of provider adoption?
Yeah, absolutely. Great question. And, building on what Martin and Steve said, when Validic launched in early 2013, what we heard fairly consistently was that was doctors saying, actually, we don't need more data. It's not, we have enough data. We have too much data already. We don't need more data. And really that's shifted, especially with regards to patient-generated health data now, to them saying, actually, we need the right data and we need to deliver it in the right way to take the right action. And so what's shifted there is not just the recognition of, oh, this data can be valuable, but it's a couple of things. One, it's a shifting payment infrastructure, which I'll touch on in a moment. The second thing is that 60% of the United States population today has one or more chronic conditions. And if you're 65 or older, that number jumps to 80%. And so a very, very large portion of the United States population has a chronic condition, which is a drain not just on the healthcare system, but on the overall economy. And third is that due to this the increased incidences of chronic conditions, we actually have more demand for care, and we have a decreasing supply of clinical staff members and physicians in the healthcare system. And so we need new ways, potentially technology-enabled ways, to actually care for more patients more effectively. And so the payment models that we're seeing really is that providers are starting to take on more risk through ACOs or other alternative payment models. They're partnering more with insurance companies. We're also seeing commercial payers starting to engage more in care delivery and care management activities, where they're actually helping their member population who have chronic conditions understand and help them map how to manage their care. We're seeing this especially within large IDNs or health systems that have plans as part of their portfolio. And then finally, we're also seeing, and this is really exciting, that CMS is stepping up with new CPT reimbursement codes for remote monitoring. So new for 2018 was a reimbursement code 99091, which reimburses for patients who are being remotely monitored in a program. That's reimbursable for $58 per patient per 30-day period. And that is a really great first step. One of the challenges with that code is that it has to be a physician who is doing the actual review of the information. The data has to be reviewed for 30 minutes in a 30-day period, which is a fairly high bar unless the physician is already spending a lot of time working with an individual patient and their data. 30 minutes is a lot of time to review. But new for 2019 are 3 proposed codes that are out for comment right now from CMS, which I highly encourage you to look up. The 3 additional codes for remote monitoring would be for the setup of a device, would be for the delivery of the data, and then finally for remote monitoring via clinical staff member. And so these new codes could really help to propel remote monitoring into the forefront of care management, supplementing the existing 99490 chronic care management code, which is currently used for care management of CMS patients with 2 or more chronic conditions. So really exciting to see the payment models advancing toward enabling and actually covering remote monitoring as part of the care continuum, because they're a really critical component to accomplishing what we all know is possible.
Poignant points made. Thank you, Drew. Sounds like there's great progress being made on the new reimbursement codes and still work to do. So let's turn our attention to the opportunities and considerations for leveraging PGHD in remote care. You know, these programs are engaging for providers and for patients. They require collecting data, reviewing data or data trends, or the interpretation of data, as Martin mentioned, and then managing the patient relationship in a new way. So Martin, what are some of the important operational considerations that providers need to make before integrating PGHD into remote care? And what practical advice can you offer them?
Yeah, thanks. I think from the experience I've gained, I would really encourage people to develop an explicit care delivery model that makes use of PGHD. I think there's still a risk of collecting PGHD because it's potentially useful, plugging it in and hoping it is going to lead to improvements. It might, but I think there's far greater value in having an explicit model for how care can be delivered. In particular, as we've now heard from a number of the inputs we've given, the remote patient monitoring, and of course some of the new other opportunities for value-based care services. So that model is not only about how we might collect and use the data, but it's how we then deliver it. And I've touched a number of times on the importance of workflows, integration with systems and processes. It's not all about integration with IT. It's about processes that exist and roles and responsibilities. Building on that, of course, then think about with a model, it becomes easy to say, what PGHD would we use and how and when would we use it and in what way? And that's going to help us begin to focus and address some of these other challenges. Information I need to collect, in what form, what level of interpretation do I need, how am I going to use it? In essence, how is it going to add value? And again, be explicit about that. That'll, of course, lead into some of the questions about the technology. How am I going to manage devices that collect the data? How are we going to collect and integrate the PGHD into our systems? And that probably will lead to a discussion about build or buy. To what extent can I do that in the systems I've got? Whether it's the clinical information systems, whether it's the data collection and management systems, analytics area of business. Some really clear discussions around that to make sure that the necessary systems are in place. Some may be already internally exist, and some may be outsourced, some may be brought in and created. I think too, we've heard some of the challenges of multiple points of data, different apps doing different things. So I think my encouragement would be focus on building an integrated, coordinated system, something that can pull multiple different types of data for different purposes into a system that itself will scale. I think we're going to see some fairly rapid advancement in new types of patient-generated health data. If we extend the scope of that even today into patient-reported measures, subjective information from the patient, social determinants of health, all those can be really valuable. We need to think about how we collect those as part of this broader system. Steve has reminded us of the importance of including patients, and it's really important that at the early stages of planning, we bring patients in, we work with them to understand their needs, their concerns, barriers, etc., and build solutions to that in from the get-go. Which talks as well about understanding other risks. What risks and concerns can we see in this process and explicitly build for solutions? Then lastly, I would encourage people to think about how we can further leverage the PGHD and the system we might have built, created. Drew's alluded to some very interesting and exciting opportunities. Clearly, CMS is moving us down this path rapidly. So think about how we could use the PGHD for performance reporting. To date, most of the performance reporting is based on hard clinical measures internal to a system. But we already see in performance reporting encouragement to make use of PGHD for performance reporting. Think about that, as well as some of these new payment mechanisms, because that can be a change maker for how interested, willing, rapidly people will adopt. Because if we now start generating revenue off this process, from the billing processes that are available, particularly from CMS, it makes a big difference to our ability to invest and therefore move forwards rapidly. So actually, there are some ideas.
Thank you, Martin. And Steve, building off of Martin's comments, how do providers effectively and authentically engage patients with chronic conditions? And how can we really ensure that communication is meaningful for patients and not just received as noise?
Thank you for that question. And I really like Martin's answer to his question. Yeah. Let me just take a step back. You know, as a patient, when I look at the medical care system, as I said before, I see it in three different phases: the diagnosing phase, the treatment phase, and the care phase. You know, people like us, like myself, that have chronic conditions, we live in the care stage. So when I step back and I look at all of what they have to offer for diagnosing for patients and doctors, you know, the lab slip that has, you know, 100 different checkpoints on it for different labs. You go down to the lab and all that technology that's down there and all that support, I think that's fantastic. Helps in the diagnosis. You look at the treatment. I walked into a hospital last year. I had to stay over for a night. That room must have had $5 million of technology in that room. And that's all over the place and seamless and supported every part of that patient in that room. That's the treatment phase. When I go to the care phase, the part that I live in with a chronic condition, I've got a meter that's really, you know, some of the technology's changed in it, but not much since I first started. It's still giving me my blood sugar value. And I got a spreadsheet that I keep my numbers on. Where's the support? Where, if you want to engage with me, engage with me. Because right now, it doesn't, you know, there's no engagement. It's a one-way conversation. It's a do this. You know, and it's hard to manage yourself with inside of this. You know, right now it's you know, it was characterized as noise. Then figure out what to do with time and way, guidance or any. And give it to the people that can get back. You know, so come connect with us. You know, the model that we use is a 50, 60-year-old model. It's the same exact model that I started with 20 years ago. You know, you imagine a phone imagine the technology that was out then. You wouldn't walk around with that phone. What do you device to manage my care every day for the rest of my life? Help me, give me some support, give me a pathway. If you connect with me like that, I'll follow you. And that's why I was successful in that program. You know, my doctor and I, you know, I gather all my data now, kind of behind the scenes, and I bring it up and we talk through that data. And I stay inside my zone. But, you know, I need the support. I need the connection. You know, I need a way. And technology is a way. We all carry around a smartphone. I think everybody on this call has one in their hand. You're all patients. Think about it from the patient's perspective and bring it. We can help. If you want to engage, you can do it. That's a way. Thank you.
Thank you, Steve. Those were critically important considerations. And Drew, how do we make these data increasingly relevant for providers, for the physicians and care managers to really ensure the same, that these data are not received as noise, but rather as impactful insights to the overall care delivery process?
Yeah, absolutely. Thanks. That's a great question. And I think I'm going to tie some of the themes that Martin and Steve just talked about together to really build the foundation for my answer. But you know, one of the things that that I will hear sometimes is how do we deal with all of this data? And at the outset, my response is a little tongue-in-cheek, but also dead serious, which is if you're asking that question, then you're doing it wrong. Because while it's true that there is a lot of data coming through from patients like Steve, for example, he mentioned he keeps a spreadsheet with all of his values. There's there's not, you know, a clinical staff member in the world who wants to receive, you know, spreadsheets of blood glucose values or other values across dozens or hundreds or even thousands of patients. It's just not something that's really sustainable. And so the important thing is to have a program of care up front where, and this is something that actually I learned from Martin, is to have a program of care up front where the clinical staff team and the patients have goals set out to begin with. And the clinical staff members have communicated with the patient and said, hey, when your values exceed this range, or when you don't take a reading in a certain period of time, I am going to be notified about that. And when I'm notified about that, I'm going to reach out and find out what's going on, right? And so you develop some accountability as well as some ground rules up front in terms of, you know, how the patient is participatory in the program, as well as how the providers are going to, and the care team members are going to receive the data. So what's important is that when you actually set up these alerts and triggers on the data, you have the data delivered in the clinical workflow in a way that the care team members are already used to receiving messages. So, you know, if they're used to receiving secure messages through their EHR, you know, make sure that you have alerts and triggers that trigger and deliver alerts in the EHR, not sending SMS messages to the provider's phone, not using a separate app that they have to log into that's outside of their clinical workflow, not via email. It has to be delivered in the clinical workflow in the way that they normally would take action on data. And that's really important. I'll give you an example. One of our clients has an alert threshold set that when patients don't record their blood pressure values in a 24-hour period, a trigger is set to send an SMS message to the patient to remind them, hey, we'd like you to record your blood pressure. Don't forget you signed up for this program. And for every 24 hours that happens, the patient receives an SMS message saying, hey, listen, you didn't perform the action that you signed up for that we agreed to. If that happens for 7 consecutive days, at that point, a secure message via the EHR is sent to the care management team so that they're alerted, hey, listen, this patient has not recorded a blood pressure value in a 7-day period. That's probably something you want to reach out for. Now, if a care team member were to look that patient up as part of their normal care management, they would probably see that in a triage list, they would see that patient wasn't adhering to their protocols, and they might choose to reach out sooner because they could see that the patient was missing reading. But regardless of that, they are definitely going to get that notice via secure in-basket message for them to actually take action on at that 7-day mark. And so that's something that it's minimally invasive to the actual care managers or clinical staff members workflow, and it's actually designed to be extremely helpful for how they can actually take advantage of the data. So at no point should they be looking at all of the data all of the time. They should always be looking at how can we use these data to just take the right action at the right time. And then the data should be available in a graphical way in the clinical workflow so that when you do have a patient encounter, you can view the data on a longitudinal chart and show how often you're out of range, how often you're in range. And that's really the kind of workflows that we work with our clients to provide so that they can actually find meaning in the data as opposed to sheer volume in the data.
Drew, thank you so much for that overview. And Martin, Drew, and Steve, thank you all for your collective insights. We're going to jump into the audience Q&A portion of this webinar. So I'm going to hand the reins back over to Claudia. But thank you all again for attending today's webinar. Just as a point of clarification, we will be sending out the recording to today's webinar within 24 hours of the end of this, along with a link to the EHI white paper that Validic and EHI jointly released at the beginning of this month, detailing the operational, financial, and clinical ROI of remote monitoring. So thank you all again, and Claudia, back over to you.
Sure. Thank you, Ashley. That was really such a fabulous discussion. We have a lot of questions. We probably won't get through all of them, but we have them recorded and we'll get back with you. Let me start off with a question to Steve. As a person who continues to seek medical care to manage chronic conditions, what do you need from a program to feel supported? And what outcomes have you been able to achieve with these types of programs?
Thank you for that question. Chronic conditions like myself that I live with are ongoing and really never ending. What I need is I need not to have a monologue with my doctor. I don't need to go there for a 15-minute appointment, just have him tell me the same old thing. I need him to engage with me and begin to have a dialogue. I think that'll make a big difference in our overall relationship. And I think it'll be, great for all patients. One of the things I heard Drew talk about are having alerts in messaging patients. We as patients have really busy lives, and we forget to take that blood pressure or that blood sugar. A reminder to keep us in the zone is great two-way communication. That I didn't take it. You tell me, you send me the message to take it. What a great partnership. I think we all have those partnerships in real life. I want to have that in my health life as well. I really want people to know that, as it's a continuous process. We need to continue not only the dialogue, the support, but the technology to bring us up to today. That part for me during that program was really important. And one of the things I wanted to share is I was able to take in a year and a half, my A1C level that was well above 8. I stopped looking at it after it was 8.3, 8.4, 8.5, and brought it down to 7. And that's a one-to-one relationship. That's the one I want. That's the one I want everyone to hear. And it's possible. You're telling us that it's out there. Let's get it in here. And make us a part of this. I think we, as patients, and as your partner, we can get there together. But if you're just telling us how to do it, and you're not providing the pathway, it's, once again, trying to get from San Francisco to New York without a guide. And the guidance is available. And I would just say, I think the doctors need this help up as well. Why can't my doctor, be able to pull up my stuff? I know he wants to. All the ones that I have dealt with was data. So I don't know where the roadblocks are or what they are, but that's the area that we're working in. The doctors are great. They're very smart and they know this, but they can't help if they don't know. They can't make that connection. They're basing it upon what I call that A1C bubble, that 3-month mirror view of what I did 3 months ago. Well, the damage is done. How do I move forward? How do I move forward every day? That's what I want the providers to know. Provide us the pathway to better health.
Thanks, Steve. I think all providers need to hear that. And there's so many patients also that have difficulty getting to the providers. So tools like this are just fabulous. I want to go on. We don't have a lot of time. And again, we will respond to your questions later. But in terms of the tools that are being used, are they HIPAA protected? And how does the FDA look at these tools and provide there's a huge question regarding the FDA. How are they approved? And how are they kept in terms of the privacy and security elements? So, Drew, could you respond to that?
Yeah, absolutely. So generally speaking, yes, these data are regarded under HIPAA and follow the similar data sharing practices of patient portability, as well as the expected security and around HIPAA. So that's something that is, generally speaking, something that we engage in and see business associates agreements signed and all of that. So yes, that does fall under HIPAA. As far as the FDA is concerned, the regulations on the FDA kind of fall into two buckets. One, if it's a medical device, such as a blood pressure monitor or a weight scale or a glucose meter, that is considered a Class 2 medical device. There's also a sort of an unregulated section of consumer devices, such as consumer wearables, that have received some interest from the FDA, and the FDA is actively looking at how they can ensure that these devices meet certain minimum thresholds for credibility, for lack of a better term. And so they have developed a pre-certification program that they're piloting with a number of these device manufacturers, including Fitbit and Apple and Samsung, to look at is there a way that the FDA can play a role in ensuring the overall just safety and baseline accuracy of the claims of these devices for consumer safety. But by and large, most of the data that we're talking about, that the data that Steve is talking about, for example, to manage his condition, already fall under the FDA Class 2 or 510K guidelines.
Thanks, Drew. Let's do one more question. How do you measure digital literacy and health literacy in the U.S.? We want the technology to narrow, not widen, health inequalities. So I don't know, Martin, maybe this is a question for you.
Well, that's a good question. By observation, I think, StarPoint is looking at the behavior of an organization, the way it understands the use of digital health, the degree to which it has explicit strategies around use of digital information. And that can fall into many areas: patient experience, IT, obviously there are legal considerations. I'm not aware, but Drew may be, of any particular measure that's used in common practice for digital literacy. But I think that's a very good question. I mean, to be used both on the provider side, and in some way it could be used, I think, to help patients, not in a pejorative sense, but a positive sense. It could be used to facilitate better understanding amongst individuals, and extend that beyond patients, because many of the people that can benefit from PGHD are in wellness programs or trying to prevent conditions that wouldn't regard themselves as patients. So I think broadening that out would be very useful. Drew, I don't know if you've got anything to add.
No, I don't, but I will. I mean, I don't know of any particular digital literacy guidelines, but I will say that one thing I love about this space is that many of these devices are consumer technology companies who exist because of their ability to engage consumers in behaviors. And it just so happens, because we're talking about patient-generated health data, these companies are engaging consumers in healthy behaviors. And as we've seen, consumer technology companies come and go, the ones that stay are the ones that have shown success in engaging patients in new ways. And I think that that's something that historically the healthcare system has been generally poor at. And so I think by partnering with consumer technology companies, that the traditional healthcare system can help close that digital literacy gap, and lean on some of the findings of these consumer technology endeavors.
Yeah, I would just add one. I would just say one thing from a patient's perspective. I agree with that, Drew. And as patients, we wear this stuff all the time. My Fitbit and Apple Watch, I mean, they track all of what I'm doing. My steps are tracked. My heart rate is, I can see it right away. Our issue is, how do we get all this data to the providers to get the feedback? There's no gateway available. So on the consumer side, I think we're getting there, and some of it is available. So how do we get it to those that can provide feedback?
Well, I think on that note, we'll go ahead and close the webinar, but I want to thank our panelists and Ashley facilitating the discussion, and Martin, Steve, and Drew. It was such an interesting discussion. We really, really appreciate your participation on the panel, and of course, thank Validic for the support of this webinar. We will be following up with the participants with the audio and link to the document, as well as responding to the questions that were not answered. So on that note, I want to thank you again, the panelists and the participants. Thank you so much.